Hello students, so far we have discussed about esophagus and stomach diseases. Now we are going to discuss about intestinal and appendix diseases of intestine and appendix. And today our topic is about typhoid and paratyphoid fever, or we can call it an infectious disease, or we can add it in gastroenterology ward, gastroenterology section, or we can add it into bacterial section. So we are going to discuss from clinical aspect like how will you diagnose and what will the criteria of your diagnosis in a medicine point of view. So what will happen, what is typhoid and paratyphoid fever? These fevers are infectious disease where it goes infectious disease caused by, if there is typhoid fever, it is caused by Salmonella typhi. And if it is paratyphoid fever, it is caused by Salmonella paratyphi. So how it is transmitted? Transmitted by fecal-oral route. And what's the incubation period? IP 7 to 21 days. So what are the risk factors? As these 3 points indicates that it's a bacteria paratyphi transmitted via fecal-oral route with incubation period of 7 to 21 days. So what is our etiology? We are going to discuss about etiology. Etiology is Salmonella enterica serotype typhi causing typhoid fever. So what is this Salmonella enterica serotype typhi? It is a gram-negative rod with flagella, pretrichous flagella. So what will it do? If we grow it on TSI agar, it will produce H2S hydrogen sulfide gas. These are oxidase negative bacteria and cannot ferment lactose. And what about paratyphoid fever? Salmonella enterica serotype paratyphi A, B, C, and serotype chlorasius. These 4 species are found subtypes which are 4 subtypes of paratyphoid fevers. So we are not going to discuss about paratyphi in details. So what is the reservoir? Like this is a bacteria, it needs a space to reserve itself. Reservoir of bacteria. In Salmonella enterica serotype typhi, reservoir is human, and other species the source is reservoir is human plus animals. So how it is transmitted? It is transmitted via fecal-oral route. So transmission, Salmonella has flagella. So let's discuss about the pathophysiology. Fecal-oral route.  'route. 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 So what will happen? As you already know that its transmission is via fecal oral route. So oral uptake of pathogen, oral uptake of pathogen in a large quantity. So what will happen when you ingest a dirty water which is contaminated with typhoid bacteria? The next thing will lead to transmission of these pathogens into distal ileum. Distal ileum. What will happen in distal ileum? There are pire patches. They migration after ingestion of or intake of pathogens from oral cavity to distal, as it reaches distal ileum, they migrate into the pair patches of distal ileum. If a pathogen manages to reach the distal ileum, it migrates via M cells through the epithelium into pair patches. You getting it? After infecting macrophages, uh, it shows non-specific symptoms. Non-specific symptoms from distal ileum to macrophages. Macrophages engulf these typhoid. As these macrophages engulf these pathogens, these, as you know, macrophages are present in blood, spread into bloodstream. And what will it cause? It cause septicemia. And what will happen after septicemia? There will a systemic disease. And what will happen? Uh, what will happen after systemic disease? These uh, pathogens migrate back into intestine and excreted via feces. So what is the virulence factor? What is the main virulence factor of these pathogens? What characteristic feature of these pathogens which is causing such features? The cell wall of typhoid pathogens contain endotoxin. This endotoxin is responsible for neurological symptoms like delirium and coma. Neurological symptoms. So how a patient will present? Like as we already discussed, and you know that the incubation period is 7 to 21 days. Most commonly 7 to 14 days. Usually it lasts long for more than 5 to 30 days. So incubation period is 5 to 30 days. Most common is 7 to 14 days. If left untreated, 3 different disease stages, each lasting a week, classically occur. So after 3 weeks of disease, there is a slow regression of symptoms. Patient may become chronic salmonella carrier, or patient may resolve disease. So we are going to discuss about clinical features, how weekly the clinical features changes. Like a patient comes to you after a patient comes to you with a history of 10 days of fever. So what will you think? And let's discuss about it in our later section. First we discuss a patient comes to you with the fever of with a rising fever of 5 days history. Body temperature, first week body temperature rises gradually. What will happen in the first week of typhoid fever or paratyphoid fever? Body temperature rises gradually. You can say step ladder pattern, but on a upper limit, there is an upper limit. What will happen? There will be a relative bradycardia, and the next thing is there may be constipation or diarrhea, or patient complains relative bradycardia, or patient complains of headache. So in week 2, my stylus is not working very accurately. I don't know why. So what will happen in week 2? In week 2, relative bradycardia. Let's make a heart here. Relative bradycardia, headache, and constipation or diarrhea. What will happen in week 2? In week 2, patient comes to you with persistent fever, but no chills. So what will you do? You will try to ask about the history, that if he had taken any medicine for to relieve or to lower his hyperthermia. See, the patient says, I took Panadols, but there is no response to Panadol. Usually in typhoid fever there is no response to antibiotics in second week. And the next clinical feature we are going to ask about is any spots on your body. Rose colored spots. Where it happens? Lower chest and abdomen, there will be rose colored spots around in abdomen, usually around, the most commonly it's around the umbilicus. In second week you will ask about, open your mouth and put out your tongue, and you will find out the tongue is of gray or yellow color. In other word, the tongue will be coated tongue. And how will you differentiate with other things? In typhoid fever there is gray yellow coated tongue with red margins, red edges. The edges will be of red in color. The next non-specific finding is abdominal pain and headache. So you will ask about his abdominal history, that any abdominal symptoms are present or not, and he will explain of yellow color, yellow green diarrhea. These clinical features are present in a second week of disease progression. So as bacterial cell wall produces endotoxin and it produces neurological manifestation, what neurological symptoms can be present in second week? These can be delirium, or patient may be in a coma state. So what will happen in third week? In week 3, patient may have clinical features of week 2, plus there will be complication of week 2 clinical features like GI bleed or GI perforation. There will be clinical features of second week and their complication. So let's discuss about GI ulcerations. So if ulcer perforate, GI ulcer perforate, you, and the next clinical feature is hepatosplenomegaly. And in rare cases, in third week, there will be sepsis, meningitis, myocarditis, or renal failure. Myocarditis or renal failure. So if a patient comes to you with diffuse or acute abdomen, and you ask about any history of diarrhea or constipation, and he tells you that he is passing black color stools or dark brown color stools, and you ask about acute abdominal history, and you find out that there is an ulceration or perforation of GI tract, and you ask about fever history, and patient tells you that he is having fever from last 24 days which is non-responsive to any antipyretic. So what will you suspect? You will suspect typhoid fever, and you will ask about his oral intake history, like if he taken any any drink from outside which is from open source, any other thing, or it is any person's food you shared having issue like fever, acute abdomen, or suffering from typhoid fever. So how will we diagnose? If the diagnosis is based on the week of clinical presentation, like we'll perform lab tests, diagnostics. What will happen in lab? As there is GI ulceration or perforation, there will be GI bleed. Patient comes to you with anemia. In hepatosplenomegaly, there is more breakdown of RBCs than normal. So anemia, what other feature? Leukopenia or leukocytosis. And when we perform liver function test, these liver function tests will be abnormal in typhoid or paratyphoid fever. How will we detect the pathogen? For pathogen detection, we'll go for blood culture. So in first week, this pathogen is detectable only in first week in blood culture. So if a patient comes to you with a 5 days history of fever and other clinical features of week 1 like relative bradycardia, constipation or diarrhea and headache, you will go for blood culture. So you do blood culture in first week. In second week, what will you do? You will do stool culture. And the third week there will be complications of um, clinical symptoms like you will go for urine examination, urine analysis. So in first week you will go for blood culture, stool culture in second week. To detect bacteremia you will go for blood culture, stool culture in second week, and in third week you will go for urine exam. Third week. So last culture you can go for is bone marrow culture. To check serum analysis or serology, we perform Vidal test for typhoid fever. Vidal test. So what is the treatment? Very simple, very easy treatment. Why? So treatment. First line treatment of typhoid or paratyphoid species fever, serotype fever is fluoroquinolones like ciprofloxacin, or you can give azithromycin if you are suspecting that patient is resistant to azithromycin. If patient is resistant to fluoroquinolones, you can give azithromycin. But in Pakistan, patients are resistant to azithromycin, so you cannot give azithromycin in Pakistan for typhoid fever. Oh, I told you on opposite. In South Asia, patients are resistant to fluoroquinolones. If a patient comes to you from South Asia like India, Pakistan, Bangladesh, you give him fluoroquinolones. You do not give him azithromycin as there is high resistance against azithromycin in South Asian countries. So the third drug we can give is third gen cephalosporin like ceftriaxone if there is severe infection. So what will happen? These antibiotics prolong the duration of fecal excretion of bacteria. So what complications can arise? Third gen. So what complication? First complication which can arise, patient can be a carrier of salmonella. What does it mean? It means you ask the patient to do a blood culture after after an year of developing typhoid fever, and you checked the stool culture of such patient, you will find out after 12 years there is positive stool culture of salmonella. So what will you do? You will ask about clinical feature. Patient says, I am having no symptoms. What will you do? You will treat him with fluoroquinolone, cephalosporins. So complications. My stylus is not working very accurately today. So you will give him fluoroquinolones. Patient can be a carrier of salmonella. After 12 months, you ask about stool culture and you find out that the patient is having positive stool culture. That's all about salmonella species, enteric fever or typhoid fever or paratyphoid fever. If you have any questions, you can ask. More than welcome.